at King Abdulaziz University Hospital, Jeddah, Assistant Professor, Rab of Medical College at King Abdulaziz University. Dr. Ghufran graduated from King Abdulaziz University in 2011 and obtained the Saudi Board of Radiology certified in 2016. She then completed a thoracic imaging fellowship at the University of Ottawa, Canada in 2018, followed by breast imaging fellowship in McGill University, Montreal in 2019. Dr. Aqili has served as a breast imaging consultant at the International Medical Center, King Abdulaziz Medical City, and King Abdulaziz University Hospital in Jeddah.
Thank you. Thank you. First, I would like to thank the committee for inviting me for this event, among with great breast radiologists, and a big thank for everyone who chose to spend the weekend with us, especially after working day. So personalized breast cancer screening has been mentioned a couple of times in the prior talks, which paved the way nicely for this presentation. I have no disclosures, and these the outlines for the presentation. So we know that 1 in 8 women will be diagnosed with breast cancer throughout their lifetime. That means each woman risk is around 13%. But does that mean that my risk is 13%, yours and hers are the same? No. Having risk factors can increase the risk up to 20 or 50 or even 70%. That's why we need to do risk stratification. To identify the risk for each woman, group them according to their level, and give them a personalized screening protocol. The high-risk women defined today as the women who have a risk more than 20% with factors related to family history, genetics, race, prior breast cancer, and the screening method has been discussed earlier, so I'm just gonna skip it. I would just like to highlight one thing. The American College of Radiology recommends that each woman should go for risk assessment at the age of 25. The risk assessment now is done with using several models, some of which are available online and some are even free. Can be used by the woman directly or under medical supervision. The commonest models to be used are Gale, Tyrer-Koziak, IBS, or Klaus. It looks like this. It is a questionnaire with some questions. This is supposed to be working, is not. That's okay. So it is a questionnaire. You just answer a couple of questions and then you get a number. That number is your risk. And then we will move into the protocol for screening. The advantage, it is available, it is easy to use, and it's kind of reliable. It is very interesting that if same woman tested by different models, she could have different results. And this is a downside for these models. So now we know that one size does not fit all. When you go for shopping, we want to fit the clothes to our size, right? And this is where breast cancer is moving. So we're going to go for image-based risk assessment, AI, and genetic-based. So I apologize for the random distribution of words. For the non-radiologist, this is a mammogram where you can see the fibroglandular tissue appearing as white, and this is the area where the cancer arises from. We're not interested in the fat. As my colleague discussed earlier, having a dense breast, like type C or D, put you in a higher risk for breast cancer. It is very simple. The more fibroglandular tissue there is, the higher the risk for breast cancer. And that's why the breast density was introduced into the risk assessment models. The first one was Tyrer-Koziak in version 8. So what's new? Why am I here today? The advances in technology improved our accuracy. So we're going to go into more details into the risk predictors. We'll look into mammogram dense volume, ultrasound glandular tissue, and MRI background enhancement. We did a good job with including the breast density, but the volume of the fibroglandular tissue differs even within the same category. So if you look at these 4 patients, we'll give them more or less the same breast density, C or D. But the volume of breast tissue is different. If you look at A and compare it to C, 60 patient with 233 cc of tissue is at a higher risk than a patient with 62 cc. And this can be calculated with a software integrated into the PAC system using 3D voxels. And it has been shown that having a larger volume puts the patient at a higher risk for breast cancer. We'll go deeper now. It's not just about the fibroglandular tissue, it's about the glandular component within the fibroglandular tissue, because breast cancer arises from the gland, not from the stroma. So if you look at the image at the lower to the right, you can see the fibroglandular tissue look more hypodense, darker. That means there is more gland, and the risk here is higher. But the first image on the top left, it's more whitish. That means it is formed by mainly fibroglandular tissue. This has been looked into in different publications, but the challenge with ultrasound, it's the same. It is operator dependent, and the measurement and classifications differs among literature. So there is no consistency to implement it compared to the mammogram dense volume. MRI background enhancement, it has been linked with risk of breast cancer. The moderate and marked enhancement have a relative risk up to 2.7 compared to the rest. The theory behind that is that the active tissue is more hormone sensitive, which make it at a risk of developing cancer. Also, it could be the fact that there is proliferative changes and probably some atypia or high-risk lesions that we don't know about. What is very interesting also, it correlated very well with interval cancers in between screenings and invasive ductal carcinoma, not DCIS, which some might say that these are the cancers we want to identify because these are the clinically relevant ones. Also, patients with dense breast, the one we said it is a risk factor, if they have minimal background enhancement, the risk is not high. While patients with low density and high background enhancement are actually related to breast cancer. So the background enhancement is more relevant than the breast density itself. Significant downside for this is the limited population where these studies conducted. So we don't really know if this is applicable to our population or not. But this is a good research area for everyone. We'll move into the AI-based risk assessment. I don't know about you, but I am crazy about AI. I think most of us it is. So the AI, it's not about what we see in the image. It's not something for us to detect. What is done basically, we give a huge amount of images into the AI tool, some with cancer, some without cancer, and we ask a simple question. Can you identify features in the cancer mammograms that are not present in the cancer-free cases? If yes, can we use this data as predictor for breast cancer or not? And it turns out the answer is yes, for a couple of markers that we will look into. Here, RadioMix tool was used to get RadioMix complexity score. It doesn't have to do anything with the image, it's just the number. So if you look at the high fibroglandular tissue images, the one in the red box is the one with high risk because the score is positive, while the other one, the score is negative. So that patient is at a lower risk. Even low density breast, for us, it is not a dense breast. This is an easy mammogram. We just love to look at it. But in reality, having a positive score, 0.7, put this patient at a higher risk. Another tool is deep learning heat map. For this, they use the deep learning tool to get the heat map. As the name says, the hotter the image, more red there is, the higher the risk of breast cancer. On the left, we are looking at images A and B. Both are dense breast, but one have more red color in it. So this patient is at a higher risk. The color does not correlate to the area where the cancer will arise. It just said that this patient is a higher risk. The other set of image C and D are for low density breast, but again, we can see a less dense breast with a large amount of red color, meaning that this is a patient at a high risk of breast cancer. Last AI-based risk assessment is actually a risk assessment model. It's not just a feature, it is a complete model similar to Gale IBIS and Klaus models. So Mirai is actually now the current state-of-art AI risk prediction model, and it was developed in 3 different countries, then validated in 5. After that, many publications validated this tool around the world. For now, you can just access their website. It is implemented in 72 hospitals in 22 countries. I just learned yesterday that it is implemented in the Saudi German hospital here in Riyadh, but I don't know if anyone is joining us from there, so I would like to talk to them. Because this model uses the same data used in the clinical models we have been using so far, adding to that the mammogram for the patient. So they add the mammogram at the image itself, and it does abracadabra, you get a risk. It's not, again, something for our naked eye to know. And actually, it outperformed IBIS and Gale models. It is open source, publicly available, so you can download it actually into your institute. AI-based model versus the current risk assessment models did a better job in detecting interval cancer with the short-term cancer, which has been a downside for the other models. The accuracy is high and improved by including other factors like breast density. So that looks so great and very interesting. Now we'll move into genetic factors. If you know, you know. In 2013, the Angelina effect happened when she became public about testing positive for BRCA1 gene, which put her in a risk for developing cancer by 65%. Most of these patients opt for bilateral mastectomy as prophylaxis, and this is what she did. Having BRCA1, BRCA2, these are the most common genes. Also, we have other genes like PALB and the one listed here. This testing for a single mutation, positive single mutation in this, is a risk factor, and this is a common test we did. We usually do, especially with young patients, where breast cancer run in families. But are these the only gene mutations that are related to breast cancer? The answer is no. We know these genes because they are high penetrance gene. Having just positive BRCA1 can increase the risk, as we said, 65%, but the relative risk in these high penetrance is from 2 to 5. Low penetrance gene, which are weaker gene to cause any harm, like PALB and CHEK, their effect is low, but there are over 300 gene mutations that can increase the relative risk by 1.5. It's so minute that no one used to care. So we're not going to test for all of this, especially that it was very expensive. But it turns out that it is important. These mutations, the mutation can be so tiny, it happens only in a single nucleotide, not the whole gene. And it's called single nucleotide polymorphism. And if you look into this, these papers, this term is used very frequently, the SNP. These low penetrance, when their accumulative risk, let's say we do a test, the patient have 90 positive SNPs. The cumulative effect can be higher than testing positive just for one BRCA gene. And that's why now they're looking into polygenic risk score. Polygenic risk score is a test calculation where hundreds of genes are tested, and you get a score for any medical condition like diabetes, hypertension, and breast cancer, of course. The combination of polygenic risk score with other factors improve risk discrimination. This sounds so great, but how do we take this into the clinical, real life? We have to integrate all of this to come closer into personalized breast cancer screening, because risk assessment is the first step. After we identify the risk, the question is going to be when and how. And speaking of when, let me see. Yeah. So with the recommendation is 40 years. And we know that there are so many national programs that actually start at 50. But as discussed earlier, we know that there are so many patients presenting in their 30s. And maybe we should look into these patients, which I will discuss in the coming slides. But first, there has been done a couple of studies, these two studies in UK in 2013, 2023, and Singapore 2022. Huge studies. They just tested the population uptake and acceptability of doing risk assessment. If we offer this, will people go for it or not? And it turns out that the result was really positive, and the implication into the system was positive. But of course, there are challenges we acknowledge, like the cost and the acceptance from the medical field. Both studies did not test the effect of personalization or risk assessment into the plan. For now, there are two ongoing huge trials that are looking into personalized screening protocols. MyPEPS, my personalized breast cancer screening, is being conducted in Europe in 5 different countries. It is a randomized controlled trials, including 85 women aged 40 to 70. They are comparing national guidelines, 2 groups in each country, national guidelines compared to risk assessment model that includes breast density and polygenic risk score. The other factors we have presented are not included in these studies. What they're looking for, their endpoint is not inferiority in detected advanced cancer. So if it is anything less than stage 2 cancer, it is irrelevant for their result. What they're doing after identify the group who will go for risk assessment will be divided into 4 groups. I will start from the first one on the left side with the low risk. They're actually proposing decreasing mammogram screening into every 4 years. It hurts, I know. I would like to see how this turns out. This study is supposed to finish in 2027, so we'll see you then. I will present the result, inshallah. Moderate risk mammogram every 2 years. High risk will get annual mammogram, and very high risk will get the annual mammogram plus annual MRI, which is basically the high risk group, which doctor already talked about. I know we don't like this, but this is this is what's happening right now. I had to present it. I'm sorry. It is in 5 European countries. I remember Spain, maybe Italy. I cannot recall the exact country they are doing this. But
same patient stable through the years, or does it increase as
they only, well, that's a very interesting question. They only test it once at their first visit. I assume that genetics are not supposed to change, but we know that's not true because they're so. Yes. Yeah. Up to my review, I haven't come across any papers that suggest repeating the test, but I think it's a very good point. So this is regarding MyPEPS. The second trial is Wisdom trial in US. Their target group is larger, 100 mammogram. Wisdom trial has 2 phases. The first phase ended in 2023, and then they started second phase, at which they include patients from 30 to 40. So at first they did not include it, but I think they said, well, things are changing. We are seeing more patients in their 30s. So this is very exciting here. And they're doing basically the same thing in the term of the group test. Here, they add for the polygenic risk score, they're looking into 96 SNPs related to breast cancer, in addition to 9 gene mutations. In MyPEPS, they did not specify the genetic test in details. Their endpoint is the same, but unfortunately, their exact protocol is not available online. So how are we going to screen? I think I just can end my talk here because this has been covered extensively. With the background, it has been already discussed, so I'm going to skip that with the limitations we know. Thank you, Dr. Samura, for the question about abbreviated MRI, because I think in the Western countries, it's been done for so many years now, and there are so many advocates for it, and I wish if we can do that, but there are a couple of limitations. So abbreviated MRI, as presented earlier, is just doing like a tiny part of the MR, not the whole study, not thousands of images, just a small set. That means that scanning time can be from 3 to 15 minutes, depending on the protocol. The protocol can differ. There are a couple of protocols online compared to standard MRI, which take 20 to 45 minutes. The interpretation time is definitely shorter because in some protocol, they only look at the map image, which is the image we see here. If there is an abnormal finding, the patient is called back for a standardized MRI, as we see in this case, the non-mass enhancement in the left breast. As also mentioned earlier, a comparable accuracy, and it is cheaper. That's why I think the insurance company should be happy about it because it is cheaper. But then I think the difficulty will be proving the second MRI that you needed to investigate it because they would say like it was already done. Why do you need it again, right? Thank God there is contrast enhanced mammogram because, as you mentioned earlier, doctor, I think it is replacing abbreviated MRI. It is great. I think patients prefer it over MRI. Less contraindications, better patient tolerance. It is faster, cheaper. Even the interpretation take less time. Implementation in hospital, buying the new mammogram machines can be a limitation, but I think we'll move there sooner or later. We know that the sensitivity is lower, but the specificity is higher. So this is a good discussion area. Automated breast ultrasound. It is an ultrasound with like a box. You can see the technician is holding there. It is the advantages include standardization of image. So the radiologist will get the same set of image. So we don't have to check and go back to discuss a lot with the technician, which save everyone's time. The patients, the technician, and the radiologist time. It is operator independent, shorter interpretation time, as I said. The performance is very comparable to handheld. It's too good to be true because there are some limitations in terms of location of the lesion. Evaluation of medial lesions, axillary tail lesion can be a challenge, as well as big breast. There is artifact that we did not use to face with standard ultrasound. It needs special training. So we need to give special dedicated training for the technician. I see them goes like, yeah, I know, I hear you. And we lose that real life image that we love about ultrasound. We miss that floating debris, the color Doppler, and the elastography as well. So in summary, one size does not fit all. Breast cancer screening should be personalized, and I believe that it will be, hopefully soon. Risk stratification is evolving from clinical models to integration of imaging, AI, and genetics. Large international trials are evaluating these risk-based screening with preservations, so stay tuned. And advanced screening techniques does add value, lower cost, and save time. These are my references, and thank you. Dr. Reen Ahmed Saif Al-Mazroui is a consultant radiologist at Sultan Qaboos Comprehensive Cancer Care and Research Center, University Medical City, Muscat. She completed a women imaging fellowship at McGill University Health Center, Montreal in 2019, followed by a breast cross-sectional imaging fellowship at McMaster University, Hamilton, 2020. She is a fellow of the Royal College of Radiologists, UK, and holds a diagnostic radiology specialty certificate from the Oman Medical Specialty Board.
Thank you, Dr. Ghufran, for this lovely introduction. I am very truly honored to be here with you, and thank you again for the invitation to be in this lovely city, Al-Ihsa, and to share our all experience in breast imaging, especially in month of October. So I want to talk about our role as a radiologist, how we can lead the service and how we can help in taking care of patients diagnosed with breast cancer, and how to work as a teamwork with other multiple disciplinaries, and how to integrate AI, the emerging AI tools, to help us in reaching the best care for the patients. Okay. So I will go through challenges in breast cancer diagnosis, what we face in reality, and what is our role, as I said, the institutional gaps and quality improvement, AI integration, and the power of multidisciplinary teamwork. So let's have a wide overview of WHO report of breast cancer globally. In 2022, about 2.3 million women were diagnosed with breast cancer, and there was a great disparity between the high socially income countries with the other relatively poor or low wealthy countries, where they have higher mortality rate and because of delayed diagnosis and access to treatment. And in that report, WHO has recognized multiple challenges, and one of them is late diagnosis, which can be multifactorial, can be related to poor awareness, stigma, and due to fragmented referral pathways where there is a delay between primary care, imaging, pathology, and then referral to oncology. Also limited access to oncology centers where the patient can get comprehensive care. Inequity of resources. These all can lead to high recurrence and mortality where patients, they cannot afford to complete treatment or to continue follow-up. So as you know, there are 3 pillars for breast cancer initiative management or pathway for the patient care, which mainly rely, the first pillar is, I cannot use that. Okay, the first pillar is where we come as detection or pre-diagnosis in screening mammogram, then the diagnostic workup, which is the second pillar, and then finally the third pillar is the treatment. So here we as a radiologist can play a major role in improving the service and reducing the delay. So I show you some statistics about the median time of abnormal imaging to reaching to diagnosis can be variable and reaching from 20 to 45 days. And even in Europe, they conducted public health analysis, and they estimated that patients, they will receive a diagnosis from time of referral to diagnosis can range from 11 to 29 weeks, which is a long time. And even in UK, they set up a target to get a diagnosis in 62 days. That was established in 2014. That was their aim. But the audits that was done recently, only 62% they reached this goal. So all of this showing the challenges that patients are facing in terms of getting diagnosis and eventually treatment. And here, why we as radiologists are very important and crucial in this role. So as I said, all these challenges caused by fragmented care, so it leads to doing multiple examinations like mammogram, ultrasound. It can increase up to 15 to 25%. The sequential approach, the patient will get imaging in one center, diagnosed in one center and others, and this will lead to repeated biopsies, like up to 12 to 18% of the cases. And radiologists sometimes in one center will be isolated from other prior imaging that was done for the patient, leading again to repetition. So that will not only affect the radiologist, it will affect the patient in anxiety, it will increase the cost, inefficient distribution of the resources between centers in the country, leading to increased cost. So why we are different? So breast radiologist is different than other all subspecialties. We are in encounter with the patient frequently. So we are directly involved with the patient care. We sometimes even end up doing counseling, breaking bad news, or getting consents for procedures. We have multiple biopsies for the same patient and sometimes in the same day. We have a lot of communication. We have to communicate with surgeon about the finding, to oncologists, to communicate with our colleague radiologists, for example, staging imaging and doing, for example, MRIs and so on. And we will continue with that patient in MDT discussions. We'll give our thought, and then in pre-surgical planning, post-op, what are the findings? So it is a closed circle that the radiologists have to be involved with the patient, which can be a big strain for the radiologist. So let's look at our local challenges. So for example, in Oman, which I think it matches many GCC countries, there is increased annual percent increased risk of breast cancer diagnosis up to 4.2%. So like, for example, in 2010, where there were diagnosed 139 cases, now it jumped to 550 cases in 2022. And unfortunately, as my colleague said, the median age of our population is mainly in the lower side, about 47 years, and a third of our cases are even below 40. Adding to that, we have limited oncology centers. Like in Oman, we have only 2 international oncology centers covering 5 million population. Most of our patients, they will come in delayed stage with stage 2 or more, 75% of the cases in our country. And this has been heavily studied by multiple publications and researchers who elaborated in the causes of delayed presentation, mainly cultural barriers, and because we don't have a national mammographic program, hopefully next year we will start it. So lack or inability of the patient to reach to the correct or to the right place for diagnosis is a major factor for our challenges. So when we started the oncology center that I'm working on in 2021, we faced many issues. First, they were referring all kind of requests for imaging, whether it is benign, whether it is screening, whether it is highly suspicious, high-risk patients. So we suffered a lot for a year or a half, a year and a half. And in that time, we tried to conduct many educational sessions to primary healthcare givers, to our colleague physicians on whom to refer and whom not. So that will reduce the referral filtration system, and we introduce the criteria for referring patients, like what are the symptoms, what are the risk factors, and how they calculate the risk factors. And then they refer. Okay, and even one of the also other challenge is incomplete or inappropriate imaging orders. They will send the patient with symptoms, palpable lump, and then they will request ultrasound, for example, without mammogram. So established a standardized imaging protocol. So for every patient, like even below 40, we request mammogram, ultrasound, MRI, biopsy, and then the radiologists decide on which one to accept and which one to reject. Also, we introduced one-stop clinic where the patient come to see the surgeon. On the same day, she will see the radiologist, will do the procedures. She will have the findings already given to the surgeon before she goes back to the surgeon. So that enhanced our flow and kept us focused on diagnosing and reaching the diagnosis in few days. Like in 3-4 days, the patient will be done from our radiology department. So that was a great achievement within a year and a half. So this is a workflow chart showing how we did it. So we receive, so through referral system, starting from the left, the surgeon will receive about 30 to 40 referrals per week, and he has to filter these cases manually. I hope we can integrate AI filtration in the future. And at the same time, when the surgeon accepts to see the patient, we will get notified that this patient will be seen in this clinic on this date. So we make a slot for mammogram, ultrasound, and even MRI if we think that this patient needs an MRI, especially if she is younger than 40, if they say it is pregnancy or lactation related. So we will make a slot available for her. And then we will see the patient, we'll do mammogram, ultrasound, needful biopsy, and MRI. And the same day, all the biopsies will be done. So that has eliminated the anxiety and the waiting time, multiple slots saving for the patient. And in the same day, we will give the report to the surgeon. So this is our enhanced workflow solution: referral, triage, one-stop clinic, appointment, same-day imaging, then pathology. It will take 1 to 3 days. We will mark the biopsy as urgent because we are suspecting either malignancy. And then we will recommend staging preparation for that patient, and the patient will be discussed in 7 days. So if I see the patient on Sunday, she will be discussed on next week, Tuesday. Okay, how can AI now, AI integration in breast cancer can help us in improving this pathway even more? So AI integration is at multiple levels. First, at referral and triage, there are already AI tools that are used by many centers, including NLP triage, which is a language processor, where it analyzes the free text from the referral. It will select specific terms, like there is a lump or nipple discharge or bloody nipple discharge or risk factor of malignancy in family history. So it will analyze this text and it will interpret it and give it prioritization for the urgent cases. So it will show in a filter as these urgent cases need to be seen in this as soon as possible. So they will be given appointments. Also, there is an AI tool with booking and workflow, like they have Epic or Qventus. These have been already studied or implemented in a few centers, like in UK, and it showed that it reduced waiting time by 30 to 40%. So it basically tests the appointments in the system and optimize the clinic and the slots by studying the patient needs and predicting which patient will come and which patient will not, and prioritize the urgent cases. So it will help to organize the workflow. AI integration in breast cancer in diagnosis, as my colleague said, it's already applied and available in many centers for mammogram. There are many tools that are available in the market that can help radiologists in getting a fast reading of the mammogram, especially the initial mammogram. And also in ultrasound, there are several AI tools like Kaios DS or Samsung S-Detect, where it detects the lesion, it gives you the location, and it gives you even BI-RAD assessment. Then MRI AI segmentation or response prediction, where it shows the color mapping and the curve analysis. There is also AI tool in pathology where it helps the pathologist to identify in very fast way whether there is a cancer or no, whether there is a metastasis in lymph nodes, and it even quantify the amount of biomarkers like ERBR, which usually takes long time. So this is really good AI tools that can be used to fasten the diagnosis of breast cancer. So let's focus on MRI, the AI-enhanced breast MRI that we used in our center, and it helped us a lot because we don't have still contrast enhanced mammogram. I hope in the future we'll get it. So basically, every patient, when we filter the request, we see if this patient is going to have a dense breast, maybe patient having prior imaging, we review the imaging. If it is already extremely dense, there is no need for me to waste the time doing ultrasound scans. So immediately this patient will be booked for MRI, and we do it as abbreviated MRI with only 15 minutes it takes. So as you can see, this is the standard MRI on the left. And this is with the color mapping, where it helps us on the same day to just have an impression or a comprehensive overview of the what's going on in the breast. So I'll show you some cases that we have a challenge with in our one-stop clinic. Like we had one patient, 38 years old, with low risk, and she presented with palpable lump in the left breast, and she is lactating. So expected that the patient breast will be extremely dense. And as you can see, although it is extremely dense, we can see there is some abnormality on the left breast. There is this asymmetry. And with tomo, it was even showing as a large area of distortion with a suspicious mass here. I cannot show it, okay. And with ultrasound, we identified the mass. It is at 12 o'clock, but we felt like from mammogram, it does not fit the whole size, like we are underestimating the tumor. So we said we will go ahead and do MRI before even sampling, because this looks suspicious by RAD5. So she did the MRI. This is with MRI contrast enhanced with the color mapping. And as you can see, there is a surprise. There is another lesion on the right breast. And actually in the left breast, it was already multifocal, multicentric. So we immediately on the same day, we are now dealing with multicentric multifocal disease on the left breast. We have a clear plan. The nipple is spared. And on the right breast, there is another lesion that needs to be sampled. And this is the curve analysis where it shows the first phase, how rapid enhancement is. And in the delayed phases, it showed washout. So the MRI report will come like this. It will show the location of the lesion, the target that I selected, and the volume and the enhancement pattern. And this will be available for the surgeon to see on the same time. I don't need to spend time to report the MRI. MRI report can wait. And this is the lesion that we saw in right breast. And in the left breast, when we did the biopsy, it came as invasive lobular carcinoma, the distortion, which fits the picture. And in the right breast, it came as invasive ductal carcinoma, which is a different tumor and HER2 positive. So that changed the whole picture and treatment plan for this patient. And eventually, patient opted for bilateral mastectomy. Another case, also again extremely dense, patient was referred for abnormal ultrasound, but the report was not clear what was the finding reported as BI-RADS 0. So we did mammogram. As you can see, the breast is extremely dense, and there is this subtle area of query distortion and mass. And in spot, it came as if it is a round mass, and there is some persistent tissue. And we did scan. I did scan at 12 o'clock upper outer quadrant, and I could not find any correlate. I actually found lymph nodes that are normal and fit this picture. But I was not convinced that there is nothing wrong with her. So we said, go ahead and do MRI. So luckily, she did the MRI, and the lesion is actually quite lateral in the breast. So it was at 3 o'clock, quite far along the axillary line. In MRI, maybe it does not reflect that, but when she is on ultrasound table, it is quite far. So we found it at 3 o'clock, 7 centimeters from the nipple, and it came as invasive ductal carcinoma, and it was just unifocal mass. Another case, 45-year-old female, she was doing screening mammogram, and we found a distortion in upper outer aspect of the breast. And with that, there were a group of calcification. I don't know if you can see it here in the spot view. There are this small group of cals, and we decided that when we did the ultrasound, we found the lesion, which is the distortion at 3 o'clock. And then we said, okay, we'll do biopsy of this under ultrasound, and we'll book her for stereo for that group of calcification just to clear it out. And then we decided, okay, better to go, because we are thinking maybe this is invasive lobular, better to go for MRI first and then decide which site to biopsy. So actually it came invasive lobular, and then she went for MRI, and this is the AI enhanced MRI report, which shows, if you can see on the left breast, it was mass with non-mass enhancement extending toward the nipple. But on the right side, there were other multiple foci in a linear fashion. So we decided to go for second look ultrasound. Second look ultrasound was negative. We did MRI guided biopsy, and it came as multifocal high-grade DCIS and papillomas. So basically, again, changing the plan. Now, no need to do stereo for the other breast. We saved her biopsies, multiple biopsies. We saved her multiple visits. And the plan again changed, and she opted again for bilateral mastectomy with reconstruction. Another patient had a mammogram that was done outside with poor quality and reported as BI-RADS 4 for the left breast, which corresponds to this asymmetry on the left side, upper quadrant. And when we did the mammogram with the proper technique, you see a large area of distortion with central mass, irregular dense mass. And again, we said we will do MRI because the ultrasound finding does not match the extent of the disease on mammogram. So on MRI, there was this big mass in the left breast. You can see here, this is the corresponding mass to the area of distortion with adjacent satellite lesions, but the rest of the parenchyma showing just significant enhancement with no concerning lesion. So it was localized disease, but we found another lesion on the right breast, quite close to the nipple, and it is bright in T2 weighted images. and it showed color washout. So we thought it could be an intramammary node, and we did ultrasound and we found it, and it was an intramammary node that looks suspicious. So we did biopsy and it came as positive for invasive ductal carcinoma. So on the left breast was lobular, and on the right breast was lymph node with another different disease. And now we have to find another focus on the right breast. So we did find only few foci, and we did MRI guided biopsy, but all came negative. So again, this is changing the plan for the patient. Okay, beside MRI and proper localization and proper staging of the disease, local disease in the breast and the other breast, our role is also goes beyond that in helping in guiding the surgeon in which modality they should stage the patient. So we conducted actually a large study, and before that, and we found out that patient with lower stage of disease, like up to stage 2 with few nodes, a few nodal disease burden, they did not benefit much from staging. There were no metastatic outcome from these patients. So we tailored our staging according to our population. And one of the things is doing PET-CT for most of the stage 2 and above cases. Then we found out that invasive lobular carcinoma sometimes it gets missed by PET scan. And now they introduced FABI PET scan, where it shows superiority compared to FDG PET-CT. So because it has a higher tumor activity and tumor to background uptake, it also detects tumor more in lymph nodes. This has been approved and already ongoing research projects. And we published few cases from this. So one of the examples, like we had a patient who came with outside biopsy proven invasive lobular carcinoma, and PET-CT was already performed outside and reported as negative. So we proceeded with MRI breast, and surprise, there were few foci seen in the clavicle that are bright in T2 weighted images, the superior image, and they showed heterogeneous enhancement in the lower image. So we advise the surgeon, just please go ahead and review that PET-CT. When we reviewed it, there were multiple small, round, and ill-defined foci in all the pelvic and all the skeletal. But this did not prove that these are metastases because there was no FDG-avid lesions. So they moved and they did FABI, and it demonstrated heterogeneous uptake in the whole spine and skeletal. So it changed the plan. Patient was planned already for surgery. Now she is metastatic. And this was proved by biopsy. So another rule for us is to have a proper evaluation of the axilla, not just looking at axillary level 1, which is lateral nodes to the pectoralis muscle. So we have an extensive approach of reviewing the nodes up to level 1, level 2, level 3, and internal mammary region lymph nodes. Why this help? This helps to assess the disease burden in the axilla and then guide us again into deciding which staging modality, whether she should go for PET or CT with bone scan, or and also in MDT discussions, many times the PET-CT will show big nodes but no uptake, and then they will end up asking us to review these nodes and say if they are suspicious or not. So we already know that this imaging characteristic by ultrasound is more sensitive. Okay. So for example, this is one patient who having multiple axillary nodes, just to show the levels of nodes. This is at level 1, lateral to the pectoralis minor muscle. Yeah, so this is the pectoralis minor muscle, and this is lateral to it, so this is level 1. And now you see pectoralis major, pectoralis minor, and these nodes that are abnormal, they are showing hypoechogenic thick cortex with flat hilum. And then there is this node at the interrotor region, which is between the pectoralis major and minor, and then the interpectoralis muscle. No, sorry, this is level 3, medial to the pectoralis, and this is the internal mammary lymph nodes. And this has been proved by PET-CT, and most of the time we are so accurate in detecting these nodes, and we are matching with the PET-CT findings or CT. So the study that we did already published in Oman Medical Journal, and it showed a large retrospective study for all our breast cancer patient diagnosed in SQH and SQCC from 2014 to 2022. And we focused mainly on early breast cancer cases from stage 0 to 2A. And we found only 2.9% of the whole cohort having metastasis. And from those, the only positive predictive value is the node status. So more patients with a node disease, they will tend to have metastasis. So that helped us to tailor our staging guidelines. So as I said, our rule, as I mentioned before, so radiologist is at the center of patient care in breast cancer, where he has to speak to the surgeon, pathologist, have to talk in MDT and use AI tools to enhance the report and diagnosis. So of course, this work will not be complete without having an expert mammographic technologist who will help you a lot in getting the most appropriate imaging positioning in mammogram, and also in helping you in filtration and appropriate booking for the patients. Also dedicated MRI technologists who can do fast protocols and change regarding the protocols according to the patient requirements. So that's all the key innovation and future direction as we talked about. So radiologist-led triage. So we are in front head of triaging and booking the patient using different modalities of AI that can help us in reaching the best outcome. So, and we are hoping in the future to get contrast-enhanced mammography so that it will lower even the days of diagnosis. So that's all. Thank you very much.
Next topic will be management of architecture distortion, represented by Dr. Maram. Dr. Maram Al-Jaid is an ABR certified breast radiologist and assistant professor of radiology at King Saud University in Riyadh, where she's also served as the deputy program director of the radiology residency program at King Khalid University Hospital. She completed her breast imaging fellowship at BI Harvard Medical School following her radiology residency at the University of Maryland Medical Center in Baltimore, USA. Dr. Jaid has authored multiple peer-reviewed publication and book chapters in diagnostic imaging, and has presented her work at international conferences, including RSNA and ARS. She is actively engaged in teaching and monitoring with a prior academic appointment at Harvard Medical School and the University of New York.
Thanks for the nice introduction. I know it's the final talk of the day, and I'll try my best to make it a little bit light. So I'll touch base on the management of architectural distortion, and at the same time, I'm going to present our research management of biopsy-proven benign architectural distortion without a tibia. Is imaging follow-up sufficient, or we have to surgically excise those lesions? Okay, no financial disclosure. So we all know since 2011, since the introduction of DBT or tomosynthesis, that the cancer detection rate has increased while the record rate has decreased, meaning that the specificity of mammography has improved significantly. With that comes a lot of detection of cancer, including the most common signs of cancer that being missed, which is architectural distortion. Which led to increased sampling of architectural distortion, because architectural distortion is at least by RAD4A. So the biopsies of architectural distortion has increased from 2% significantly to 17.7%. With that comes a lot of learning about the behavior of architectural distortion and how serious it is. There was a meta-analysis that was published by Mayo Clinic Group in 2020, and they studied the positive predictive value of architectural distortion. And they found that the architectural distortion is as the positive predictive value of malignancy is as high as 34%, even in the absence of sonographic correlate. And with the presence of the sonographic correlate, the malignancy probability will shoot up into 78%, meaning we cannot assign biradity or follow-up for architectural distortion that proved itself it's real on imaging. They also found that architectural distortion, even if it is only one few, like if it is only detected on the CC or in the MLO, and if it is only tomosynthesis detected, not even 2D detected architectural distortion, it is still concerning, and the probability of malignancy is at least 10%, meaning that it is PIRAT for at least. So, to summarize the literature review, that DBT increased cancer detection rate, as well as the biopsy rate of sampling architectural distortion. Here to emphasize again that the positive predictive value of architectural distortion is at least 34%, meaning that it mandates sampling. Causes of architectural distortion, as we all know that it is broad, benign more than malignant. For the malignant causes of architectural distortion, radial scar or complex sclerosing lesion is one of the most common reasons. Sclerosing lesions, meaning sclerosing adenosis, sclerosing papillomas, or any type of sclerosing behavior at the histopathological level. One of the very common reasons post-treatment changes, diabetic mastopathy, fibrosis, and on the malignant side, tubular sclerosis, a prognosis with a cancer with very good prognosis at subsite of IDC, ILC, and even DCIS sometimes can present as architectural distortion. So, as we said that radial scar and complex sclerosing lesion is one of the most common reasons of architectural distortion, and it was the area of interest in our research is radial scar and complex sclerosing lesion. Mainly, what is radial scar? It is a misnomer. It is not a real scar, but it was named as a scar because it mimics a scar both on imaging and in histopathology. Like here, sorry, I don't, pointer probably doesn't work. So we can appreciate the 3D mammography that the radial scar looks like a real scar, both also in ultrasound. And on MRI, typically radial scar or complex sclerosing lesion present as an area of non-mass enhancement. And at the histopathology result, you can appreciate like the scar or the radiating spicules without a central mass. Complex sclerosing lesion, by definition, is the same entity, but the size is bigger, more than 1 centimeter. And usually radial scar complex sclerosing lesion is an incidental finding. So when we, with the introduction of DBT, which lead to increased sampling of architectural distortion to 17.7%, there was a lot of retrospective studies, and actually not a lot, it's like a few retrospective studies that decided to re-examine our recommendation for radial scar and complex sclerosing lesion. Is it really a high-risk lesion? Do we really need to excise those? So a retrospective study was done at the MGH in Boston 2023, and they found that the epigrade rate for radial scar that was well sampled, concordant, and benign without associated atebia goes from 2% to 2.2%, which led them to ask, is it worth it to send those patients to surgical excision? This study was led by another group led by Dr. Jordana Phillips in Boston University, and they came to the same conclusion. So that led us to ask the same question: should we send our patients to surgical excision if we found radial scar on initial sampling, or we should not? So our study was a retrospective study that was conducted in a tertiary care center from the area to, we retrieved the studies from 2013 to 2022. It is HIPAA compliant and IRB exempted. We retrieved and included all mammographic studies, whether it is screening or diagnostic mammography, breast ultrasound, breast MRI studies, or contrast enhanced mammography that was positive for architectural distortion in the impression. We excluded any cases that was not, we didn't have final confirmation at surgery, patients that were lost for follow-up, discordant rad bath results, architectural distortion that we could not reproduce at the day of the diagnostic imaging workup, and one of our patients were jumped directly into surgery without initial sampling. So the outcome of our population was we collected around 285 cases, and 120 of those cases that was positive for architectural distortion were benign without associated atipia. 23 of them, they have associated atipia with initial sampling, like ALH, LCIS, and ADH. And 73 patients were biopsy-proven malignant architectural distortion. So our interest group was for the benign architectural distortion without atipia. We retrieved 120 cases out of 285. And out of the 120 cases, 44% of those patients ended up with surgical excision. And when we examined the surgical specimen, we found that none of those patients were upgraded into malignancy, invasive component, or DCIS. And only 7 of those patients with initial benign biopsy that was concordant, they have a small focus of atipia on surgical excision, atipia like a small focus of ALH or ADH. The second set of our sample was the patient who has initial architectural distortion associated atipia, and none of them were upgraded into invasive component, but only 5 patients were upgraded into DCIS. And we thought that the leading factor was the atipia itself rather than the distortion. The remaining of the cohort were malignancy-proven architectural distortion. When we examined further that the subgroup that was benign architectural distortion without atipia and with no upgrade into malignancy or atipia on surgical specimen, we found up to most of them were complex sclerosing lesion and radial scar. So this is the first case for a patient with screen detected right upper outer architectural distortion. We have a protocol to any patient we call back from screening for architectural distortion to do contrast enhanced mammogram, because as one of the presenters mentioned, that contrast enhanced mammogram specificity is high, and the lack of enhancement essentially rule out possibility of malignancy. So we can appreciate in this case that the contrast enhanced mammogram did not show corresponding enhancement to the area of reported architectural distortion. We followed that by targeted ultrasound to the area of the upper outer breast and the area of distortion. And we found this area of hypoechoic non-mass finding that was then sampled. The biopsy result was breast tissue. However, when we looked at the post-biopsy mammogram, the clip really did not land where the architectural distortion was. So the patient was sent to surgical excision. And on surgical excision, it was just breast tissue, papilloma, and complex sclerosing lesion. For the second patient, this is a high-risk patient with screen-detected left upper outer architectural distortion. We can see that we appreciate the distortion in both 2D and 3D mammography. We called her back, the distortion is real, and we did targeted sonographic ultrasound. So for the ultrasound, we appreciated 2 lesions at the area of interest at 1:30 o'clock and 2:30 o'clock. And we decided to sample both lesions. The ultrasound-guided biopsies were sclerosing lesion, which explained the distortion, PASH, and apocrine metaplasia. The patient went then for surgery, and the lesions of distortion were excised. Sorry, here in the post-biopsy, I skipped one step. So the post-biopsy mammogram showed that both the clips correspond, or the upper outer ribbon-shaped clip correspond to the area of distortion. So the patient went for surgical excision, and the excision was complex sclerosing lesion, papilloma, no atipia, no malignancy. This is a third case that highlights that we need to take into consideration risk versus benefit in managing our people, that sending patients all the time to surgical excision for benign architectural distortion might lead to over-treatment and harm rather than benefit. This is a patient who was referred to us from an outside hospital. She is 55 with non-biopsy-proven benign complex sclerosing lesion, no atipia. So the surgeon decided to take her to the OR, excise the area of what thought to be a high-risk lesion, and it was only a sclerosing lesion, no upgrade. However, her post-operative course got complicated by breast abscess, chronic inflammation, and nipple necrosis, unfortunately. So we need to be mindful and reminded that us as breast radiologists play a critical role in patient treatment and must be mindful that surgical excision for all architectural distortion, particularly those without associated atypia, might result in harm and over-treatment of our population. You can see from our result that 0% of our patients were upgraded to malignancy, which is concordant to what's been reported in the literature. This is a study done and published by Brown University Group in 2021. And they did a retrospective study, but that was geared only to radial scar. And they retrieved around 146 cases of radial scar on initial sampling. And when they tracked them down, they found those who did not have initial malignancy or atypia and went to surgery, almost none of them got upgraded into malignancy, except one case. Fortunately, even the arrow here doesn't work. So 78% of those patients were sent to surgery, and 77% of them were benign, and only one patient got upgraded into malignancy, which is thought to be undersampling rather than real upgrade into malignancy. Our result also is concordant with the pathology data set. There was a huge meta-analysis done in Australia that included more than 3,000 cases of radial scars. And they found that the possibility of upgrade to malignancy was inversely proportional to the quality of the sampling. So the smaller the needle, the higher the likelihood that we are undersampling, and the patient and the probability of upgrade reaching up to 5%. The bigger the needle, and when we use vacuum-assisted device, the upgrade rate was dropped into 1%, which encouraging us when we sample architectural distortion to be very mindful of the quality of our samples. The data result was also concordant with the surgery literature review. They almost report the same findings. Okay, so what is next? So we have two options: whether we follow up those patients, or we find another alternative to make sure that we're not missing cancers. Especially from all of us agree that our population is a high risk population, and we want to make sure that we are not missing occult malignancy. This is a nice article that was published by Dr. Vandana Dayalani and Jordana Phillips at BI, Boston, and they found they did a prospective study where they sent any patient who was diagnosed with architectural distortion and was booked an ultrasound to MRI, and the lack of enhancement essentially ruled out the possibility of malignancy. Given the high specificity and negative predictive value of MRI. It's an overwhelming diagram without a pointer. So the conclusion is, if you have an architectural distortion and it is not sampled and you do not have sonographic correlate and there is no enhancement, essentially you are saying this is benign, and you can just like for the ease of your mind, you can follow it up. If there is a sonographic correlate, the probability of malignancy might go a little bit high, but again, we know MRI is perfect. And if there's no enhancement, essentially we are saying there is no cancer and we can follow them up. So sometimes I use this to minimize the multi-steps cancer workup in terms of absence of enhancement, whether in contrast enhanced mammogram or on MRI, but we need to be very mindful that we see good contrast in the vessels, that the parenchyma is well perfused. So the conclusion on that paper that imaging follow-up rather than biopsy may be consideration for patients with architectural distortion and mammogram without an ultrasound correlate. Okay, so I promise to be short and concise. So in conclusion, architectural distortion is a serious thing. It is the third most common cancer signs. It's the most common finding that's missed on malignancy on mammogram. However, the positive predictive value for malignancy is high, reaching up to at least 10%, which justifies sampling. Do not follow architectural distortion. The presence, even in the absence of ultrasound correlate. The grade rate for initially well-sampled and concordant benign architectural distortion is very low, from 0 to 2%. In other words, it is BI-RADS 3. So which justify that imaging follow-up would be a reasonable alternative rather than excision. In the RCNA 2023, the BI-RADS Lexicon Committee, in their prelim data that they released, they dropped down complex sclerosing lesion, radial scar, and papilloma to benign lesions rather than high-risk lesions. The data is not released yet, but it seems that all the recent workup is concordant with these findings. Thank you.